Okay, imagine your body is like this incredibly complex machine, always running checks, always sending out reports. And some of the most vital signals, really detailed reports, they come from our kidneys, right? And what we find when we analyze blood and, yes, even urine.
They really are intricate diagnostic puzzles, those reports. When you learn how to truly read them, they unlock some profound insights into how well the body's maintaining its delicate balance, its homeostasis.
Yeah.
Think of those lab results, those urine findings, not just as numbers on a page, but more like coded messages from a really critical organ system.
Exactly. And our mission today is to go deep, to decode those messages together. Welcome to the deep dive. You've shared some key source material with us, specifically focusing on a foundational chapter about kidney function and dysfunction, and we're going to unpack it all. Our mission, to dive deep into Chapter 52, focusing on azotemia and urinary abnormalities, and really pull out the core concepts, the diagnostic logic, the why behind the findings. We're aiming for that level of understanding that feels like, true mastery.
Yeah, this chapter provides the essential framework. It's how we understand the ways disturbances in normal kidney function manifest clinically in ways we can actually detect. It's not just about memorizing facts. It's really about understanding the underlying physiology and how it breaks down.
Now, before we jump right into Chapter 52 proper, the source material you provided does start with a brief discussion of something called interstitial cystitis, or bladder pain syndrome, ICBPS.
Right.
It's worth just touching on because it highlights how chronic conditions affecting the urinary system, maybe not directly the kidney filters themselves, but they can still cause significant disability, severely decrease quality of life, and have real mental health impacts.
That's a key point.
The text mentions the global challenges in confirming its true prevalence, while also acknowledging it's not just limited to, say, Western populations.
And it suggests a necessary approach. Multimodal, interdisciplinary. Recognizing the psychosocial aspects, the importance of addressing mental health right alongside the physical symptoms. It gives us a little glimpse into the complexity of these chronic urinary tract issues.
Absolutely. But for this deep dive, where the core of Chapter 52 and where the real density of information is, we're focusing specifically on the broader renal syndromes, the ones driven by problems with kidney filtration and how the kidney handles substances, particularly azotemia and those detailed abnormalities you see in urine. That's where we're really concentrating our energy today.
Precisely. So our journey will take us from defining those fundamental patterns of kidney dysfunction, the renal syndromes. Then we'll spend significant time really digging into azotemia, what reduced kidney function means, and crucially, how we measure it, including all the complexities and the caveats.
Okay.
Then we'll explore the major categories of acute kidney issues, prerenal, postrenal, and intrinsic problems, and try to understand the distinct ways they present. And finally, we'll spend detailed time breaking down exactly what it means when you find things like excess protein or blood, different types of cells, and those really telltale casts in the urine. Plus understanding abnormal urine volumes too.
By the end of this, our goal is for you to be able to look at a set of kidney labs, maybe a urinalysis report, and have the tools to interpret them more like an expert, seeing the patterns, understanding the why, and recognizing the nuances.
That's the aim, getting to that mastery level.
Get ready. Let's start decoding the language the kidneys speak. All right, let's dive into segment 1. The language of the kidney's renal syndromes. The text opens by grounding us in the fundamental role of the kidneys. Maintaining homeostasis.
Yeah.
It's all about keeping the body's internal environment stable, right? Balancing fluid, electrolytes, acid, removing waste.
And when that crucial balance gets disturbed, it doesn't just create random chaos. The kidney dysfunction tends to manifest in these recognizable patterns, which the text calls renal syndromes. It's really important to grasp that these syndromes aren't single diseases themselves. They're more like constellation-specific groupings of abnormal findings that point towards an underlying issue.
So it's like a set of symptoms, maybe physical signs you might detect, and crucially, changes in lab tests that tend to show up together. They point towards a specific kind of underlying problem. It's sort of the kidney's way of signaling distress, and these syndromes are like the different distress signals it sends out.
Exactly. And these patterns can arise in broadly 2 main ways, either from a systemic illness that affects the kidneys as part of a wider disease process, or from a primary disease that actually originates within the kidney itself.
Okay. And the text lists 7 key findings that are essentially the building blocks of these syndromes. These are the core abnormalities you're looking for. First up, and well, arguably the most central, is a reduction in the glomerular filtration rate, the GFR. This is really highlighted as the primary metric of overall kidney function.
It absolutely is. It's the best single indicator we have of how well the kidneys are doing their main job of filtering the blood. The other building blocks include abnormalities of the urine sediment. That's what you actually see under the microscope when you spin down the urine sample.
Like cells and things.
Yeah, red blood cells, white blood cells, those casts we mentioned, crystals, other cellular debris. Then there's abnormal urinary excretion of serum proteins. We call that proteinuria. This tells you something's potentially wrong with the filter itself, or maybe the tubules downstream.
Disturbances in urine volume are another key element, whether the kidney is producing too little urine, that's oliguria, or even anuria, or maybe too much urine, which is polyuria.
Right. We also often see the presence of hypertension, high blood pressure, and/or an expansion of the total body fluid volume, which usually shows up as edema, swelling, particularly in the legs or maybe around the eyes.
Electrolyte abnormalities are very common too, because the kidneys are just central to regulating the balance of crucial electrolytes like sodium, potassium, calcium, phosphorus, bicarbonate. So problems there can have widespread effects.
Definitely. And finally, in some syndromes, especially those involving infection or inflammation, you might see systemic symptoms like fever or pain.
So the real power here, and what the text emphasizes, is that the specific combination of these 7 findings is what allows us to identify the major nephrologic syndromes. It's not just one symptom in isolation, but how they cluster together.
Like notes forming a chord. Yeah, that's a good analogy.
So if you see reduced GFR plus significant protein in the urine plus swelling, that collection of findings points strongly towards something like nephrotic syndrome.
Right.
But if you see reduced GFR plus red blood cells and maybe specific types of casts in the urine, that points more towards, say, an acute nephritic syndrome or glomerular nephritis.
Precisely. Looking at that specific combination really helps narrow down the possibilities, the differential diagnosis, and it guides the subsequent workup, the diagnostic evaluation, and the treatment plan. The text lists examples in Table 5201, things like acute renal failure, which we often call AKI now, chronic renal failure, CKD, rapidly progressive renal failure, RPGN, nephrotic syndrome, acute nephritic syndrome.
Also, asymptomatic urinary abnormalities, like just finding protein or blood without other symptoms, UTIs including pyelonephritis, renal tubular defects, hypertension itself, kidney stones, nephrolithiasis, and urinary tract obstruction.
Right. Each of those represents a distinct pattern formed by different combinations of those 7 basic building blocks. And as the text notes, our deep dive today will focus on the core elements that this chapter goes into in really extensive detail. Reduced GFR, which is azotemia, the alterations in urine sediment and protein, and the abnormalities of urinary volume.
Yeah.
These are arguably the most fundamental clinical indicators of underlying kidney issues. Mastering these is truly foundational to understanding nephrology.
Which brings us directly to segment 2, azotemia understanding reduced kidney function, specifically that GFR. Let's start with the term itself, azotemia.
Okay. Azotemia is a clinical term. It's defined as a rise in nitrogenous waste products in the blood. The main ones we measure are urea, often reported as blood urea nitrogen or BUN, and creatinine. This rise typically reflects a significantly reduced glomerular filtration rate, the GFR.
So it's basically the accumulation of stuff that the kidneys should have filtered out but couldn't because the filter, the glomerulus, isn't working effectively enough. And the text really hammers home why GFR is so incredibly important, calling it the primary metric for kidney function.
Its role in clinical medicine is paramount.
Yeah.
It goes far beyond just diagnosing kidney disease. A really critical reason GFR is measured and tracked is for drug dosing. Many medications are cleared from the body primarily by glomerular filtration. So if the GFR is reduced, the drug isn't cleared as quickly, its levels build up in the blood, and this can lead to serious toxicity, side effects, and tragically even death if drug doses aren't appropriately adjusted for that reduced kidney function.
That's a huge practical implication right there.
Yep.
So how do we actually measure this vital GFR? The text talks about an ideal method, but notes it's not really used much in practice.
The ideal, the gold standard, involves directly measuring the clearance of a substance that behaves perfectly at the glomerulus, meaning it's freely filtered, but then it's neither reabsorbed back into the blood nor excreted into the urine by the kidney tubules later on.
Something that just passes through.
Exactly. Substances like inulin or radiolabeled iophthalate fit this bill. If you infuse them and then carefully measure how much appears in the urine over a specific time relative to their concentration in the blood, you get a very precise measure of the actual filtration rate.
Because every molecule that gets filtered ends up in the urine. Makes sense.
Yeah, it's a direct quantification of the volume of plasma filtered per unit time. But performing these tests requires continuous infusions, really precise timed urine collections, complex lab analysis. It's generally too cumbersome and expensive for routine clinical use. It's mostly reserved for research settings or maybe very specific, complex diagnostic questions.
So in reality, day to day, we rely on surrogate markers. And the absolute workhorse of kidney function assessment is plasma creatinine, or PCR.
Yes, plasma creatinine. It's a waste product generated from the breakdown of creatine phosphate in muscle tissue. It's released into the blood at a relatively constant rate, determined largely by a person's muscle mass. And like inulin, it is freely filtered at the glomerulus.
And the fundamental relationship is pretty simple. As GFR falls, the concentration of creatinine in the plasma rises because it's not being cleared as efficiently by the kidneys.
Precisely. The text illustrates this with that inverse relationship. However, this is where the first really important caveat comes in. Plasma creatinine does not rise linearly with declining GFR, especially in the early stages.
What does that mean in practice? How does that play out?
It means that you can actually lose a significant amount of kidney function, perhaps even 50% or more of your baseline GFR, before the plasma creatinine level even starts to climb above the upper limit of the normal lab range.
Wow.
So a normal creatinine number does not guarantee a normal GFR, especially if someone started with a particularly high baseline GFR, maybe due to large muscle mass, or conversely, if their muscle mass has decreased over time due to illness or aging.
That's a critical detail. You can have substantial kidney damage brewing before the standard lab test looks technically abnormal.
Absolutely. And furthermore, the clinical symptoms of kidney failure, that state we call uremia, things like fatigue, nausea, loss of appetite, itching, maybe confusion, they typically only become apparent when the GFR is very, very low, usually below about 15 millimolar.
That's quite advanced.
Very advanced. This means relying solely on symptoms or even just initial changes in the PCR can definitely miss earlier stages of kidney decline where interventions might be most effective.
And PCR levels are influenced by so much more than just the GFR, right?
That's right. They are significantly affected by a person's muscle mass, which naturally varies with size, age, and sex. Underlying chronic illnesses, taking steroids, or being malnourished can cause muscle wasting, which lowers PCR production, and that can make the GFR seem better or higher than it actually is.
Okay.
Diet can temporarily affect it. Eating a large portion of cooked meat, for instance, can increase PCR for a few hours because meat contains creatine, which converts to creatinine. Certain medications can also interfere with either creatinine secretion by the tubules or even the laboratory measurement itself.
The text mentions a specific tool for tracking chronic progressive kidney disease using PCR, plotting 1 divided by PCR against time.
Yes, that's a valuable clinical trick. In many types of chronic progressive kidney disease, if you plot the reciprocal of the plasma creatinine, 1 PCR against time, you often get a surprisingly linear relationship, a straight line sloping downwards.
So if you're tracking a patient over months or years, and their 1 PCR plot is following that straight line down,
that suggests a relatively consistent rate of kidney function decline, characteristic of their underlying chronic disease. But if that line suddenly deviates, if it takes a steeper drop downwards,
that's a red flag.
That's a big red flag. It strongly suggests a superimposed acute process causing a more rapid loss of function than the chronic disease alone. This should prompt an immediate investigation for something new, like acute kidney injury layered on top of their chronic kidney disease. Maybe they got dehydrated, started a new potentially toxic medication, or developed an obstruction.
Okay, so plasma creatinine on its own has these significant limitations. What about creatinine clearance, or CRCL? The text presents this as another way to estimate GFR.
Right, CRCL is considered an approximation of GFR. It involves collecting urine over a specific period, most commonly 24 hours, and then measuring the total amount of creatinine excreted in that urine collection, as well as the average plasma creatinine level during that same period.
And the formula is given. CRCL equals urine volume times urine creatinine concentration, divided by plasma creatinine concentration times the total collection time in minutes. Essentially calculating the volume of plasma cleared of creatinine per minute.
Yes. And to make sure that 24-hour collection is actually reliable.
Hmm.
That the patient managed to collect all their urine without missing anything. The text discusses assessing its adequacy or completeness. You look at the total volume collected, but maybe more importantly, you calculate the total amount of creatinine excreted per kilogram of body weight per day.
Okay.
The text gives expected ranges, for instance, roughly 15 to 20 milligrams per kilograms per day for men, and maybe 10 to 15 milligrams per day for women, reflecting differences in average muscle mass. If the total amount excreted falls significantly below this expected range, the collection was likely incomplete, and the calculated CRCL result won't be accurate.
That makes intuitive sense. Your daily creatinine output should be pretty consistent based on your muscle mass. But even a complete CRCL collection has its caveats, doesn't it?
Absolutely. While creatinine is primarily filtered at the glomerulus, a certain amount is also actively secreted into the urine by the proximal tubules. This tubular secretion actually becomes more significant as kidney function declines, especially when the GFR is quite low.
So the tubules are adding extra creatinine to the urine after it's been filtered.
Exactly, which means the total amount of creatinine excreted in the urine is actually more than what was just filtered by the glomeruli.
So this leads to an overestimation of the true GFR by the CRCL calculation.
Precisely. So even a carefully performed 24-hour creatinine clearance might give you a number that's slightly higher than the person's actual GFR, and this degree of overestimation tends to be greater in more advanced kidney disease.
Given the practical difficulties of getting accurate timed urine collections and the limitations of both PCR alone and CRCL, in most outpatient settings, we tend to rely on estimated GFR, or eGFR, calculated using specific formulas.
Yes, these formulas use readily available patient data, typically plasma creatinine, age, sex, and sometimes race, to provide a calculated estimate of GFR without needing any urine collection at all. The text mentions the older, widely used formulas, Cockcroft-Gault and the MDRD, modification of diet and renal disease equation. It notes that the MDRD equation generally performs better when the GFR is already known to be below 60 in a Wareham.
And then it introduces the newer CKD-EPI equation, which is now generally the preferred one in most places.
Right. The CKD-EPI, Chronic Kidney Disease Epidemiology Collaboration equation, was developed using more extensive and diverse data sets. These data sets included individuals both with and without known kidney disease, and importantly, their GFR was often directly measured using gold standard methods like iothalamate clearance for comparison.
So it was validated against more accurate measurements in a broader population.
Exactly. This broader base and direct comparison to measured GFR seems to make the CKD-EPI a more accurate estimator of GFR overall, across a wider range of kidney function compared to the older formulas.
The CKD-EPI formula itself is quite complex, involving PCR, age, and sex, but it famously included, at least initially, a specific coefficient, 1.159, that was applied if the patient self-identified as Black or African American.
And this specific detail brings us to a very important point highlighted in the text, and one that's been the subject of significant discussion, debate, and change in recent years. The inclusion of a race modifier in eGFR calculations.
Okay.
The text explains the original rationale based on the data used to develop the equation. In that specific development cohort, Black individuals, on average, were observed to have a measured GFR that was about 16% higher compared to non-Black individuals who had similar age, sex, and plasma creatinine levels.
So the modifier was put in to try and adjust for that observed average difference in that study group, aiming to provide an estimate that theoretically aligned more closely with the measured GFR for Black individuals within that specific population.
Exactly. It was an empirical adjustment based on the available data at the time, intended to improve the accuracy of the estimate for that group.
Okay.
However, as the text clearly points out, this practice has faced considerable scrutiny.
Why is that?
Well, the text notes that race is primarily understood as a social construct, not a precise biological determinant. Using a self-reported social category to modify a clinical laboratory result carries significant weight and has real-world implications.
Right.
This scrutiny has led many medical laboratories and professional organizations, as the text indicates, to recommend stopping the routine use of the race modifier in eGFR calculations. Now, labs might report a single eGFR value calculated without the race coefficient for all individuals, or sometimes they might report values both with and without it.
And the text discusses the potential consequences of removing this modifier. What are they?
On the positive side, a major projected consequence, and one that's been a driving force for the change, is potentially improved equity in access to the kidney transplant waitlist for Black patients.
How does that work?
Because the race modifier previously increased the calculated eGFR for Black individuals, it meant some patients might not have been classified as having CKD severe enough, meaning a GFR below a certain threshold, like 20 mmol/min, to be added to the transplant waitlist until later stages of their disease compared to non-Black patients with the same creatinine level. Removing the modifier results in a lower calculated eGFR for these individuals, potentially allowing them to qualify for waitlisting earlier, which could improve outcomes.
That seems like a very direct and significant potential benefit. Does the text mention any potential negative consequences or concerns about removing it?
Yes, the text presents it as a balanced discussion, noting potential downsides raised by some. These include a possible overdiagnosis of CKD in some Black individuals whose estimated GFR was previously boosted above a diagnostic threshold by the modifier. This could lead to increased patient anxiety, perhaps unnecessary further testing, or labeling someone with a chronic condition diagnosis they might not technically have at that severity level based on other criteria. There's also a theoretical concern mentioned about potential inadequate drug dosing for some individuals if their true GFR is actually higher than the new, lower estimate calculated without the modifier, although this needs to be weighed against the benefits of standardized reporting and avoiding potential under-recognition of kidney disease. The text also briefly mentions potential reductions in living kidney donation among Black individuals, though without detailing the specific mechanism behind that concern.
So it's presented as a complex situation with various factors and potential trade-offs. The overall move seems to be towards removing the modifier based on clinical equity and social considerations, acknowledging the limitations of using race as a biological proxy, even despite the original statistical observation in the development dataset. It really highlights that even with our best formulas, there are still significant limitations and ongoing refinements.
Absolutely. And the text reminds us that all these creatinine-based estimates, whether it's CRCL from a 24-hour urine or an eGFR calculated from a formula, fundamentally assume a relatively stable state. They assume stable creatinine production, stable excretion, and a stable GFR.
Which isn't always the case.
Right. They are much less reliable when GFR is changing rapidly, like during acute kidney injury. And as we touched on earlier, gradual changes in muscle mass over time due to chronic illness, maybe steroid use or malnutrition, can significantly affect the plasma creatinine level and therefore mask true changes in the underlying GFR if you're just following the numbers.
Are there any other markers that can help, especially when these creatinine estimates might be less reliable?
The text introduces cystatin C as a promising alternative, or perhaps more accurately, an adjunct marker. Cystatin C is a protein produced at a fairly constant rate by virtually all nucleated cells in the body.
Not just muscle cells.
Correct. Unlike creatinine, its production rate isn't significantly influenced by muscle mass. It's also freely filtered at the glomerulus, and then, unlike creatinine, it's almost completely reabsorbed and metabolized by the proximal tubules, so it doesn't normally appear in the urine in significant amounts.
So its blood level is also inversely related to GFR. As GFR falls, cystatin C rises.
Yes, exactly. And because its production isn't tied to muscle mass, it's proposed as potentially being more sensitive for detecting early declines in GFR, particularly in individuals where creatinine might be misleading due to unusual body composition, very high or very low muscle mass. It's also less affected by self-reported race than creatinine-based estimates were historically.
Are there things that do influence cystatin C levels, though?
Yes. The text notes it's not perfect either. It is influenced by factors like sex, the presence of diabetes, smoking habits, and levels of systemic inflammation. So while it offers advantages, it has its own confounders.
So it's not a magic bullet.
No, but it's increasingly used as an adjunct to creatinine-based eGFR, especially when the creatinine result seems inconsistent with the clinical picture, or in populations where creatinine is known to be less reliable. Combining estimates based on both creatinine and cystatin C can provide more robust and potentially more accurate assessment of GFR.
Wow. Okay, that was a really deep dive into just how we measure kidney function, and it's clearly way more complex than just looking at a single creatinine number on a lab report. So we understand reduced GFR, azotemia, and its measurement limitations. Now, what do we do when a patient actually presents with this finding with azotemia? How do we figure out why their kidney function is down? Segment 3. The approach to azotemia, acute versus chronic, and the causes. The text makes the crucial point that the very first step, the absolute first question when you find azotemia, is determining whether the kidney problem is acute or chronic. This is fundamental.
Absolutely fundamental, because it completely changes your diagnostic approach, the urgency of the situation, and, critically, the potential for reversibility.
How do we usually tell the difference?
Often, the clinical history, the patient's presentation, and other laboratory data provide important clues. For instance, a sudden onset of symptoms like decreased urine output or a known recent exposure to a potential kidney toxin strongly points towards an acute problem.
Whereas long-standing symptoms like fatigue, maybe anemia found on previous labs, or a known history of abnormal kidney tests would suggest a chronic issue.
Exactly. Some lab findings typically associated with chronic kidney disease, CKD, like anemia, due to reduced erythropoietin production, or abnormalities in calcium and phosphorus metabolism, can sometimes appear in severe acute cases too, but they are much more consistently present in established chronic disease.
Is there any single finding mentioned that's definitively indicative of chronic disease?
The text mentions radiographic evidence of renal osteodystrophy, specific bone changes caused by long-standing kidney failure, and altered mineral metabolism as a definitive sign of chronicity. But, and this is a really crucial point, renal osteodystrophy is a very late finding.
You wouldn't see it early on.
No, it's typically only seen in patients who already have end-stage kidney disease, often those who have been on dialysis for some time. So you absolutely cannot rely on finding renal osteodystrophy to distinguish acute from chronic disease, in most cases presenting with new azotemia.
So for earlier differentiation, what are the key tools the text emphasizes?
The text points to urinalysis and renal ultrasound, as illustrated nicely in figure 52:1, as essential first steps in the evaluation. On renal ultrasound, the classic findings that suggest chronic kidney disease are kidneys that are bilaterally small in size.
Shrunken,
yeah. Often with increased echogenicity, they appear brighter or whiter on the ultrasound image, which reflects scarring and fibrosis within the kidney tissue and often show cortical thinning, meaning the outer layer of the kidney is thinner than normal. Essentially, they look scarred down and damaged from a long-term process.
So conversely, if the kidneys are normal size or even enlarged on ultrasound, it's generally less likely to be a long-standing chronic disease, although there might be exceptions like polycystic kidney disease or amyloidosis causing enlargement.
Correct. Kidney size is a very helpful clue. And on urinalysis, patients with established chronic kidney disease often have some degree of persistent proteinuria. Their urine is often non-concentrated. We call this isosthenuria, meaning the urine osmolality is similar to that of plasma, reflecting the damaged tubule's inability to concentrate or dilute urine effectively. And sometimes you might see broadcasts in the sediment.
Broadcasts.
Yeah, these are wider than other types of casts and are thought to form in tubules that have become significantly dilated and hypertrophied over years of damage and compensatory changes. So finding broadcasts suggests chronicity.
Okay, so once we've determined, or at least highly suspect, that the problem is acute renal failure, or AKI, the text breaks down the potential causes into three major categories. These are absolutely critical to remember.
Yes, the big three categories responsible for acute azotemia, as clearly outlined in figure 52:1. Prerenal causes, postrenal causes, and intrinsic renal disease.
Let's start with prerenal azotemia. What does that mean?
Prerenal means the problem originates before the kidney itself. Specifically, it involves inadequate blood flow to the kidney's insufficient renal perfusion. The kidney structure itself might be fine initially, but it's not getting enough blood flow or pressure to maintain adequate filtration.
And the text highlights this is really common.
Extremely common. It's the most frequent cause of AKI, accounting for a large percentage, somewhere cited between 40% and maybe even 80% of cases presenting with acute kidney failure.
And the good news is it's often readily reversible if you can identify and correct the underlying perfusion problem quickly.
That's the absolute key. If you restore adequate blood flow promptly, the kidney function usually recovers fully. The causes are basically anything that reduces the effective circulating blood volume or systemic blood pressure. Think about straightforward volume loss.
Like bleeding, severe burns, persistent vomiting or diarrhea, maybe taking too many diuretics.
Exactly. Or conditions like adrenal insufficiency. Then there's third spacing of fluid, where volume shifts out of the blood vessels in other body compartments, like in acute pancreatitis, severe peritonitis, or extensive muscle breakdown in rhabdomyolysis.
Or situations where the total body fluid might even be high, but the effective arterial volume perfusing the organs is low, like in severe congestive heart failure, advanced liver cirrhosis with lots of ascites, or distributive shock like sepsis.
Right. In those cases, the blood is physically there in the body, but it's not effectively circulating and reaching the kidneys with adequate pressure. You can also get impaired renal perfusion due to widespread peripheral vasodilation, like in sepsis or anaphylaxis, or sometimes due to profound renal vasoconstriction.
This last one is important and often related to underlying disease or drugs.
Such as?
Seen in severe heart failure where the body is trying to maintain pressure, and hematuria syndrome, which is a complication of advanced liver failure, or significantly, due to medications like NSAIDs, non-steroidal anti-inflammatory drugs, or sometimes after receiving iodinated contrast media. This leads us right into the really fascinating and clinically critical physiology the text describes about how the kidney tries to protect its own filtration rate when blood pressure drops, and how certain common drugs can interfere with this protective mechanism.
It's a beautiful and vital system. When systemic blood pressure falls, especially below a mean arterial pressure of about 80 millimole Hg, the body kicks in major compensatory mechanisms. The sympathetic nervous system is activated, the renin-angiotensin-aldosterone system, RAAS, ramps up, and vasopressin, also called ADH or AVP, is released.
Hormonal responses.
Right, and within the kidney itself, at the level of the glomerulus, there are crucial local adjustments. Locally produced prostaglandins cause vasodilation of the afferent arteriole, that's the small artery bringing blood into the glomerulus. At the same time, angiotensin II, generated via the RAAS activation, causes vasoconstriction of the efferent arteriole, the vessel carrying blood away from the glomerulus.
Okay, so the in-pipe opens up wider and the out-pipe squeezes down.
Exactly. Which has the net effect of increasing the hydrostatic pressure within the glomerular capillaries, helping to maintain the pressure gradient needed for filtration, even when the overall systemic blood pressure coming into the kidney is reduced.
A clever autoregulation mechanism.
It's crucial for maintaining GFR in the face of fluctuating blood pressure. And this is precisely where common medications become so relevant and potentially dangerous in the wrong setting. NSAIDs like ibuprofen or naproxen work by blocking the production of prostaglandins.
So they block that afferent arterial dilation.
Correct. If someone is hypotensive or volume depleted and their kidneys are relying on that prostaglandin-mediated afferent dilation to maintain blood flow into the glomerulus, taking an NSAI blunts this vital compensatory response.
And what about drugs like ACE inhibitors, like lisinopril, or ARBs, like losartan?
They work by blocking the effects of angiotensin II. So they prevent that crucial angiotensin II mediated efferent arteriolar constriction. If someone is volume depleted or hypotensive and their kidneys are dependent on angiotensin II constricting the efferent arteriole to keep glomerular pressure up, taking an ACE inhibitor or an ARB inhibits this compensatory mechanism.
So putting it together, a patient who is hypotensive or significantly volume depleted, especially if they happen to be taking both an NSAI and an ACE inhibitor or ARB, has essentially lost their kidney's main tools for maintaining GFR under stress.
Exactly. They are highly susceptible to developing hemodynamically mediated AKI because their kidneys simply cannot effectively maintain the necessary filtration pressure when systemic blood flow or pressure is compromised. The text specifically highlights the significant risk this poses for patients who already have underlying conditions that impair renal perfusion at baseline, like bilateral renal artery stenosis, narrowing of the arteries to both kidneys, or stenosis in the artery to a single functioning kidney.
Why are they particularly vulnerable?
Because in those situations, the kidney downstream of the stenosis is already experiencing low perfusion pressure. It becomes critically dependent on angiotensin II mediated efferent constriction just to maintain any significant filtration pressure at all. Giving these patients an ACE inhibitor or an ARB can remove that last line of defense and cause a precipitous, sometimes catastrophic drop in GFR.
That's a really critical clinical concept to understand. The text also points out that while prerenal azotemia is initially a functional problem and reversible if perfusion is restored, if that period of inadequate perfusion ischemia is prolonged or severe enough, it can actually lead to structural damage to the kidney tubule.
Yes. Prolonged or severe ischemia directly damages the kidney's tubular epithelial cells, causing them to dysfunction and even die. This transitions what started as a functional prerenal state into a structural intrinsic kidney disease, specifically acute tubular necrosis or ATN.
Which is a form of damage within the kidney itself.
Correct. And this brings us to the key laboratory tools the text uses to help distinguish between simple prerenal azotemia, where the tubules are still working, and established ATN, where the tubules are damaged. This distinction is detailed in Table 52-2 and Figure 52 to Serre. The core difference lies in the integrity and function of those kidney tubules.
Okay, so in prerenal states, the tubules are still healthy, and they're actively trying to conserve salt and water to help restore the body's circulating volume, right?
Exactly right. The body senses low volume or low pressure and sends signals, like aldosterone and AVP, telling the kidneys to hold on to every last bit of sodium and water. The healthy, intact tubules respond appropriately by avidly reabsorbing sodium from the filtrate.
And what does that look like in the urine tests?
It results in urine that is highly concentrated with a high osmolality, typically greater than 500 millismoles per liter. The urine sodium concentration is very low, usually less than 20 milliequivalents per liter, because the tubules are pulling it all back into the body. The fractional excretion of sodium, or FINA, which tells you the percentage of the sodium that was filtered by glomerulus that actually ends up escaping in the urine, is very low, typically less than 1%.
So less than 1% of the filtered sodium is being excreted.
Right, indicating very efficient tubular reabsorption. And the ratio of urine creatinine concentration to plasma creatinine concentration, the UCR-PCR ratio, is high, usually greater than 40. This is because as the tubules reabsorb water, the creatinine left behind in the tubular fluid becomes more concentrated relative to the plasma level. Finally, the urine sediment under the microscope is usually bland or unremarkable. You might see a few hyaline casts, which are just protein aggregates, or maybe some fine granular casts, but no significant evidence of actual tubule cell damage.
Okay, that's the picture in prerenal. Now, contrast that with acute tubular necrosis, ATN, where the tubules themselves are damaged by the ischemic or toxic insult.
Precisely. In ATN, the damaged tubular cells lose their ability to effectively reabsorb sodium and concentrate the urine. So you typically get urine that is less concentrated, often with an osmolality similar to plasma, around 300 or sometimes less than 350 mosmol. The urine sodium concentration is higher, usually greater than 40 MEQL, because the damaged tubules can't reabsorb it properly.
They're leaking sodium.
In a sense, yes.
Yeah.
They fail to reabsorb it. Consequently, the FINA is higher, typically greater than 2%, indicating that the kidney is inappropriately losing a larger fraction of the filtered sodium into the urine. The UCR-PCR ratio is lower, usually less than 20, because water reabsorption is also impaired, so the urine creatinine doesn't get concentrated as much relative to plasma. And critically, the urine sediment is active.
What does active mean here?
It means you see evidence of the tubular damage under the microscope. You'll find cellular debris, maybe shed tubular epithelial cells themselves that have sloughed off the damaged tubules, and often those characteristic muddy brown granular casts.
Ah, the muddy brown casts. That's the classic finding for ATN in the sediment, isn't it?
It is. They're essentially aggregates of cellular debris and proteins, primarily Tam-Horsfall protein, incorporating fragments of dead or dying tubular cells, giving them that distinct appearance. Finding them is strong microscopic evidence of acute tubular injury.
Okay. Now, the text adds a crucial nuance about FINA that's important for that mastery level understanding. It's not always perfectly clear cut.
Right. While a FINA greater than 2% is highly suggestive of ATN, the text points out you can sometimes see a FINA less than 1% in milder forms of ATN, particularly non-oliguric ATN, where urine output is still maintained. And perhaps more importantly, patients who have severe underlying conditions that cause intense systemic sodium retention, think advanced congestive heart failure or cirrhosis with hematuria syndrome, often have very high levels of aldosterone and other signals telling the kidney to save sodium.
So even if they develop ATN on top of that?
Exactly. Even if they develop some degree of tubular injury, ATN, the overwhelming systemic drive to retain sodium might still result in a low urine sodium concentration and a low FINA, less than 1%, mimicking a prerenal picture based on that number alone. So in those specific clinical contexts, the FINA can be misleading, and you really need to consider the entire clinical picture, including the urine sediment findings and the patient's underlying diseases, to make the distinction. It's not always black and white based on one number.
That level of detail is really valuable. Okay, let's move to the second major category of AKI, postrenal azotemia.
Postrenal means the problem is occurring after the kidney specifically. There's an obstruction to the outflow of urine somewhere in the urinary tract, from the renal pelvis down to the urethra. The text states this accounts for a smaller percentage of AKI cases, maybe less than 5%, but it's absolutely critical to identify and rule out because, like prerenal AKI, it's often rapidly reversible once you relieve the obstruction.
And to actually cause kidney failure, the obstruction usually has to block urine flow from both kidneys, right? Because normally one healthy kidney can compensate if the other one is blocked.
That's generally correct. The obstruction must be bilateral, affecting both ureters or the bladder outlet urethra, or it must be unilateral, affecting only one side, but occurring in a patient who only has one functioning kidney to begin with.
What kinds of things cause obstruction?
Common causes include kidney stones lodged in both ureters, or a stone blocking the outlet of a solitary kidney. External compression of both ureters by, say, tumors in the pelvis or retroperitoneum, or maybe retroperitoneal fibrosis, scarring. At the level of the bladder outlet, you could have benign prostatic hyperplasia, BPH in men, bladder cancer, or neurogenic bladder dysfunction, or problems in the urethra like strictures.
And the primary diagnostic tool for suspecting postrenal obstruction is usually renal ultrasound.
Yes, renal ultrasound is typically the first imaging test ordered when obstruction is suspected. It's looking primarily for hydronephrosis, which is dilation of the renal pelvis and the ureters proximal to above the point of obstruction. This dilation indicates that urine is backing up due to the blockage.
But the text includes an important caveat here too, doesn't it? About ultrasound.
It does. While finding hydronephrosis is the classic sign, the ultrasound can sometimes be negative or non-diagnostic in the very early stages of acute obstruction before significant dilation has had time to develop. Or in some situations, the ureters might be encased or restricted by surrounding tissue, like in cases of severe retroperitoneal fibrosis or certain invasive tumors. In these scenarios, the ureters might not be able to dilate much, despite being functionally obstructed and causing increased pressure upstream.
So a negative ultrasound doesn't absolutely 100% rule out obstruction if the clinical suspicion remains high.
Correct. If the clinical story strongly suggests obstruction, like a patient with known pelvic cancer presenting with anuria, but the initial ultrasound is negative, other imaging studies like a non-contrast CT scan of the abdomen and pelvis, or sometimes a nuclear medicine rentgenogram, a kidney scan, might be needed to definitively confirm or exclude the diagnosis.
Got it. So always consider the clinical picture. Finally, that brings us to the third major category, intrinsic renal disease.
This is the category you land in, essentially by exclusion, after you've reasonably ruled out prerenal and postrenal causes for the acute kidney injury. Intrinsic renal disease means there's damage occurring directly to the kidney parenchyma itself within the actual kidney tissue.
And this damage can affect different parts of the kidney.
Right. The damage can primarily involve the large renal blood vessels, arteries or veins, the smaller microvasculature like the tiny arterioles and the glomeruli, the filtering units, or the renal tubules and the surrounding interstitial tissue, the tubulointerstitium.
And the text says that ischemic and toxic acute tubular necrosis, ATN, which we've already discussed quite a bit, are by far the most common causes of acute intrinsic renal failure.
Yes, they account for the vast majority, maybe around 90% of cases within this intrinsic category. Ischemic ATN, as we covered, is often the end result of prolonged or very severe prerenal hypoperfusion that leads to actual tubular cell injury and death. Toxic ATN results from direct damage to the tubular cells by various medications, drugs of abuse, or endogenous or exogenous toxins.
Why are the tubules so vulnerable to toxins?
The kidney tubules are particularly susceptible for a couple of reasons. They receive a very high blood flow, delivering potential toxins directly to them, and their job involves reabsorbing water and concentrating substances from the glomerular filtrate, which means the tubular cells can be exposed to very high concentrations of potentially toxic substances that were present in the blood at lower levels. They also actively metabolize some substances, sometimes creating toxic byproducts.
So the diagnostic approach when you suspect ATM after ruling out pre- and postrenal causes is really to look hard for evidence of preceding hypotension or hyperperfusion that could have caused ischemia, and to meticulously review the patient's exposures for any potential nephrotoxins.
Exactly. You're hunting for the ischemic hit or the toxic culprit. Common nephrotoxins to consider include aminoglycoside antibiotics like gentamicin, amphotericin B, certain chemotherapy agents like cisplatin, heavy metals like lead or mercury, ethylene glycol, antifreeze, and important endogenous toxins like myoglobin released during rhabdomyolysis or free hemoglobin released during massive hemolysis. The good news about ATN is that often, if the underlying insult, the ischemia or the toxin, is removed or resolves, the tubular epithelial cells have a remarkable capacity to regenerate, and kidney function can recover, sometimes fully, over days to weeks.
Okay. What about other types of intrinsic AKI? The text mentions tubulointerstitial processes.
Right. These diseases primarily affect the renal tubules themselves and the interstitium, which is the connective tissue framework surrounding the tubules. The most common cause of acute tubulointerstitial nephritis, AIN, is an allergic or hypersensitivity reaction to a medication.
Which drugs are common culprits?
The text lists several classic culprits. Certain antibiotics, particularly penicillins, cephalosporins, and sulfa drugs. NSAIDs are another major cause. Proton pump inhibitors, PPIs, used for acid reflux, are increasingly recognized. Some diuretics, like thiazides and furosemide, can also cause it. Basically, a wide range of drugs can potentially trigger AINE in susceptible individuals.
Can other things cause AI besides drugs?
Yes. Severe infections within the kidney, like bacterial pyelonephritis, also cause inflammation in the tubulointerstitium. And certain systemic diseases can manifest with tubulointerstitial nephritis, including autoimmune diseases like systemic lupus erythematosus, SLE, sarcoidosis, Sjogren's syndrome, and certain types of lymphoma or leukemia infiltrating the kidney.
What would you typically see on your analysis in acute tubulointerstitial nephritis?
You'd usually see some degree of proteinuria, though typically mild to moderate, not in the nephrotic range. Hematuria, blood in the urine, is common, and pyuria, the presence of white blood cells in the urine, is very common, found in about 75% of cases. You might also sometimes see white blood cell casts, which indicate that the inflammation is happening within the tubules themselves.
But the text provides a crucial caveat here for differentiating things based on casts, right?
Yes, a very important one. If you see pyuria and hematuria, and maybe even WBC casts, which point towards tubulointerstitial inflammation or infection, but you also find clear red blood cell casts in the urine sediment, that should immediately broaden your thinking.
Why?
Because, as we'll discuss more, RBC casts are a much stronger indicator of damage to the glomeruli. So finding RBC casts, even in the setting of apparent interstitial inflammation, should prompt serious consideration and evaluation for underlying glomerular diseases, like glomerulonephritis or vasculitis.
So WBC casts point more to tubulointerstitial inflammation infection, but RBC casts, even if WBCs are also present, strongly signal a glomerular problem that needs investigation, often including a biopsy.
Precisely. Renal biopsy is often necessary to definitively diagnose the specific type of tubulointerstitial disease and rule out glomerular involvement. The text also specifically addresses the topic of urinary eosinophils. Those are white blood cells with pink staining granules. For decades, the classic teaching was that finding a significant percentage, like 1% or 5% depending on the source, of eosinophils in the urine using a special stain like Hansel's or Wright's was a strong indicator, almost pathognomonic, of allergic interstitial nephritis, particularly drug-induced AINE.
But the text basically debunks this idea.
It does, quite emphatically. It states that subsequent studies have shown that urinary eosinophils can be increased in many other causes of AKI, including ATN, pyelonephritis, cholesterol emboli, and even some glomerular diseases. Therefore, the presence or absence of urinary eosinophils has essentially no reliable diagnostic utility in distinguishing between different types of renal disease, and specifically, it should not be relied upon to diagnose allergic interstitial nephritis.
That's a really important update to a commonly taught clinical pearl. So don't hang your hat on urinary eosinophils.
Definitely not. It's a crucial detail for achieving that up-to-date mastery-level understanding and avoiding diagnostic errors based on outdated concepts.
Okay, what about problems affecting the large renal blood vessels? Is that common?
Occlusion or severe stenosis of the main renal arteries or veins is a relatively uncommon cause of AKI overall, but when it happens, it's often dramatic and severe. Similar to obstruction, it usually needs to affect both kidneys, bilateral disease, or the vessels supplying a single functioning kidney to cause a significant global reduction in GFR.
What causes these large vessel blockages?
Acute arterial occlusion can be due to several things. Atheroemboli are common. These are fragments of cholesterol plaque that break off from diseased areas, usually in the aorta, often dislodged during procedures like cardiac catheterization, aortic surgery, or even spontaneously. These cholesterol crystals travel downstream and lodge in smaller renal arteries, causing inflammation and obstruction.
Okay.
You can also have thromboembolic blood clots traveling from elsewhere, like the heart and atrial fibrillation, or in situ thrombosis, a clot forming right within the renal artery, aortic dissection that extends into and blocks the renal arteries, or vasculitis, inflammation of blood vessels that affects the large renal arteries.
What are the clinical clues or lab findings that might suggest atheroembolic AKI specifically?
Atheroembolic AKI often occurs in the days or weeks following an aortic procedure. Patients might have other signs of emboli elsewhere, like levato reticularis, a characteristic purplish, lacy, mottled pattern on the skin, often on the legs, painful blue toes, digital infarcts, or signs of emboli to the gut or brain. Blood tests might show eosinophilia, an elevated eosinophil count in the peripheral blood. The urinalysis in atheroembolic AKI is often relatively bland, maybe showing mild proteinuria, some hematuria, and sometimes eosinophils or hyaline casts, but usually not the heavy sediment seen in ATN or the RBC casts of GN.
So the diagnosis is often clinical based on the timing and associated findings.
Often, yes. Renal biopsy can confirm the diagnosis by showing the characteristic cholesterol clefts within the small arteries, but it's invasive and not always necessary if the clinical picture is strongly suggestive. Acute renal artery thrombosis or thromboembolism typically presents with sudden severe flank pain, often nausea and vomiting, and a rapid loss of kidney function. Urinalysis might show some hematuria and proteinuria. Renal vein thrombosis is a bit different. It's often associated with heavy proteinuria, sometimes even the full nephrotic syndrome, which makes patients hypercoagulable and prone to clots like RVT, significant hematuria, and flank pain. Diagnosing these large vessel occlusions usually requires specific vascular imaging, like Doppler ultrasound, CT angiography, or MR angiography.
Finally, within the category of intrinsic renal disease, we have diseases that primarily affect the glomeruli themselves and the small microvasculature within the kidney.
Yes. This group includes conditions like the various forms of glomerulonephritis, GN, systemic vasculitis affecting small vessels like ANCA-associated vasculitis, hemolytic uremic syndrome, HUS, thrombotic thrombocytopenic purpura, TTP, and severe hypertensive emergencies like malignant hypertension. These diseases directly damage the tiny filtering units, the glomeruli, or the small blood vessels within the kidney parenchyma. They often present with a characteristic clinical picture known as the acute nephritic syndrome,
which is a specific constellation of findings like the syndromes we discussed earlier.
Exactly. Acute nephritic syndrome is typically characterized by a combination of reduced GFR, often presenting as AKI, proteinuria, which is usually present but typically less severe than in the full nephrotic syndrome, often in the 1-3 gram per day range, hematuria, which is often macroscopic, visible, or microscopic, and crucially, often contains dysmorphic, abnormally shaped red blood cells and red blood cell casts, and altered sodium handling by the damaged kidneys, leading to sodium and water retention, which manifest as hypertension, edema, and sometimes signs of circulatory congestion, fluid overload.
And these glomerular diseases can be primary kidney diseases, or they can be the kidney manifestation of a systemic illness.
Correct. Examples of primary GN include IgA nephropathy or post-infectious GN. Yeah. Systemic diseases that commonly cause nephritic picture include lupus nephritis, ANCA-associated vasculitis, or anti-GBM disease, Goodpasture syndrome.
And the text highlights again that key, highly specific urinalysis finding that points strongly towards glomerular disease.
The absolute red flag. The finding that is considered virtually diagnostic of glomerulonephritis and is usually a strong indication for pursuing an early renal biopsy is the presence of red blood cell casts in the urine sediment.
Can you explain again exactly how these form?
Sure. When the glomerular filtration barrier is damaged by inflammation or injury, red blood cells can leak through from the blood capillaries into Bowman space and then enter the tubular lumen. As these red blood cells travel down the nephron, particularly in the distal tubules and collecting ducts where urine flow might be slower and concentration occurs, they can get trapped within a cylindrical protein matrix, primarily composed of TAM-horsefall protein, which is normally secreted by the tubules. This mixture of protein and trapped red cells forms a cast, a mold of the tubule shape, which is then eventually flushed out in the urine.
So seeing those microscopic cylinders packed with red blood cells definitively tells you that the bleeding originated high up in the nephron, meaning the red cells must have come through a damaged glomerulus.
Precisely. It localizes the source of the bleeding to the glomerulus. While RBC casts are highly specific for glomerular bleeding, the text importantly notes they are not very sensitive, meaning you can definitely have significant glomerulonephritis without finding RBC casts in the urine, especially if the disease process is mild focal, or if the urine sample examined isn't optimal.
So their absence doesn't rule out GN.
Correct. Hematuria without casts can still certainly be glomerular in origin. That's where looking for those dysmorphic red blood cells becomes helpful again. As we mentioned, examining the urine sediment carefully, ideally with phase contrast microscopy, to look for those oddly shaped crenated or blebbed red blood cells, like acanthocytes, provides another strong clue pointing towards a glomerular source of bleeding. Although this technique also has caveats regarding observer variability and the potential influence of urine pH and osmolality on RBC shape.
So for suspecting glomerular disease, you're really looking for that cluster of findings. Proteinuria, often nephritic range, hematuria, especially if dysmorphic cells are seen, and the really key finding, if present, is RBC casts. This whole evaluation process is nicely summarized in Figure 52-2, which guides the clinician towards further tests like serologies for systemic autoimmune diseases or often proceeding to a kidney biopsy for definitive diagnosis.
Understanding that specific constellation of findings in the urine sediment and protein measurement is absolutely key to recognizing potentially serious glomerular disease early.
Let's quickly just revisit oliguria and anuria, which were mentioned again here as potentially severe presentations of AKI. Remind us of the definitions.
Oliguria is generally defined as a urine output of less than 400 milliliters, ml, in a 24-hour period. Anuria is even more severe, typically defined as less than 100 milliliters of urine output per day, sometimes even less than 50 milliliters.
And what typically causes true anuria? It sounds ominous.
It usually signifies a very severe or complete disruption of kidney function or urine flow. The text lists the major causes: complete bilateral urinary tract obstruction, postrenal, a catastrophic vascular event like bilateral renal artery occlusion or dissection, or perhaps bilateral renal vein thrombosis, severe ischemic conditions leading to widespread renal cortical necrosis, death of the outer kidney tissue, certain overwhelming intrinsic diseases like myeloma cast nephropathy, where light chain casts completely clog the tubules, or just extremely severe widespread acute tubular necrosis. It can also sometimes be precipitated by a combination of drugs like NSAIDs plus AC inhibitors plus diuretics, particularly in a severely hypovolemic patient, essentially causing a profound prerenal state that rapidly transitions to severe ATM or severe shock states.
And the text makes the point that oliguria, even if not complete anuria, is never normal.
Correct. A typical adult needs to excrete at least around 400 milliliters of urine per day, even if it's maximally concentrated, just to get rid of the minimum daily load of metabolic waste products, sulfates. So producing less than that always indicates a significant problem with kidney function. However, the text also contrasts this with non-oliguric ATN.
What's that?
That's a situation where the patient clearly has tubular injury, ATN, and their GFR is significantly reduced, but their urine output remains greater than 400-500 milliliters per day. This form of ATN tends to be associated with less severe electrolyte and acid-base disturbances, because waste products can still be flushed out to some extent, and generally carries a more favorable prognosis with a quicker recovery compared to oliguric ATN.
So simply having some urine output doesn't automatically mean the kidneys are fine if the GFR is still significantly reduced and there's evidence of tubular damage.
Exactly. Urine volume is just one piece of the puzzle. You have to consider the GFR and the urine composition too.
Okay, we've spent a lot of really important time on understanding reduced GFR, azotemia, and the different causes of acute kidney problems. Now, let's shift gears slightly and look in more detail at the specific abnormalities we find in the urine itself, the protein, the cells, the casts, and finally, the volume changes that manifest as polyuria. This is segment 4, abnormalities in the urine.
Right. And proteinuria is perhaps one of the most common and clinically significant urinary abnormalities that points towards underlying kidney damage. It's often first detected using a simple urine dipstick test.
Dipsticks are easy, quick, widely available, but the text provides some really crucial nuances about their limitations that are key for accurate interpretation.
This is vital. A standard urine dipstick primarily detects the protein albumin. It's much less sensitive, or completely insensitive, to other types of protein that might be present in the urine. False positive results for protein can occur if the urine is highly alkaline, pH greater than 7.0, if it's very concentrated, or if it's significantly contaminated with blood, as blood contains protein. And maybe most importantly, if the patient's urine is very dilute, say they drank a lot of water before the test, the albumin concentration might fall below the dipstick's detection threshold, leading to a false negative result, even if the total amount of albumin being excreted over a 24-hour period is actually elevated. The dipstick reads concentration, not total daily excretion.
So a negative dipstick doesn't necessarily rule out a significant protein problem, especially if you're concerned about non-albumin proteins, or if the patient is very well hydrated and producing dilute urine. How do we get a more accurate quantification of protein excretion then?
The text describes several methods that are better than a simple dipstick. A spot urine albumin to creatinine ratio, ACR, preferably measured on a first morning voided urine sample, which is usually more concentrated and reflects the overnight excretion rate, is a very useful screening and monitoring test, particularly for detecting diabetic nephropathy early.
ACR.
Yes. The ratio of albumin in milligrams to creatinine in grams in a spot urine sample correlates reasonably well with the total albumin excretion over 24 hours in MEGDAY. The text also helpfully updates the terminology here. What was previously often called microalbuminuria usually defined as 3,300 milligrams of albumin per day, is now preferably termed moderately increased albuminuria, corresponding to an ACR of 3,300 milligrams, and what was called macroalbuminuria or overt proteinuria, greater than 300 to 3,500 milligrams, is now called severely increased albuminuria. ACR 300 milligrams or 3,500 milligrams if measured over 24 hours in nephrotic syndrome.
Okay, so ACR for albumin specifically. What about total protein?
For estimating total protein excretion, including non-albumin proteins, you can use a spot urine protein to creatinine ratio, PCR or UPCR. Similar to the ACR, the ratio of total protein to creatinine in spot sample gives a rough estimate of the 24-hour total protein excretion in grams per day. For example, a PCR of 3.0 mB/g or a GD approximates about 3.0 grams of total protein excretion per day.
But the gold standard is still.
The gold standard for truly quantifying the total amount of protein being excreted over a full day remains a formal, timed 24-hour urine collection, specifically measuring total protein, usually reported in milligrams per 24 hours. This is especially important if you suspect significant non-albumin proteinuria, where the ACR or even the PCR might underestimate the problem.
And this brings us right back to that critical point about dipsticks missing non-albumin proteins, particularly those Bence-Jones proteins in multiple myeloma.
This cannot be emphasized enough for clinical practice. Bence-Jones proteins are free immunoglobulin light chains, either kappa or lambda, produced in excess by abnormal plasma cells in conditions like multiple myeloma. These light chains are small molecules, small enough to be freely filtered by the glomerulus. However, they can overwhelm the normal reabsorptive capacity of the proximal tubules and therefore appear in the urine, often in large quantities.
And the standard dipstick won't pick them up.
Correct. The standard urine dipstick is insensitive to these light chains. Missing significant Bence-Jones proteinuria can lead to a dangerous delay in diagnosing multiple myeloma, which can cause severe and often irreversible kidney injury through several mechanisms described in the text. These light chains can be directly toxic to the tubular cells. They can aggregate with Tam-Horsfall protein to form large obstructing casts within the tubules. This is called myeloma cast nephropathy, a common cause of AKI and myeloma. Or they can deposit in the kidney tissue itself as amyloid fibrils, amyloidosis, or non-fibrillar deposits, light chain deposition disease, causing chronic damage.
So if multiple myeloma is suspected based on other clinical or laboratory findings, like anemia, bone pain, high calcium, or a high total protein with a low albumin, specific tests for urinary light chains, such as urine protein electrophoresis, UPEP with immunofixation, are absolutely essential. You cannot rely on a negative dipstick.
Absolutely crucial for patient safety. Now, just for context, the text reminds us that normally, healthy individuals excrete less than 150 milligrams of total protein per day, and of that, less than 30 milligrams should be albumin.
What makes up the rest of that normal protein?
The remaining normal urinary protein consists mainly of proteins that are actively secreted by the tubules into the urine, like Tam-Horsfall protein, also called uromodulin, some immunoglobulins like secretory IgA, and enzymes like urokinase. There are also very small amounts of small plasma proteins, less than 20 kilodaltons in size, that get filtered but are normally almost completely reabsorbed by the proximal tubules.
So finding excess protein in the urine, proteinuria, generally indicates a problem with either the glomerular filter letting too much through, or maybe the tubules failing to reabsorb the small proteins they normally handle, or sometimes excessive secretion.
Primarily, significant proteinuria usually points to a problem with the glomerular filtration barrier, or, less commonly in terms of massive protein loss, a problem with tubular reabsorption, tubular proteinuria. The text explains the mechanism of glomerular protein loss beautifully by describing the sophisticated structure of the glomerular filtration barrier.
Remind us of the layers.
It's an incredibly elegant, multi-layered filter designed to let water and small solutes pass freely from the blood into the Bowman space, the beginning of the nephron tubule, while effectively retaining blood cells and large proteins like albumin within the bloodstream. It consists of three main functional layers. First, the capillary endothelium lining the glomerular capillaries. These endothelial cells have pores, called fenestrations, which are relatively large and block blood cells but allow plasma and large molecules through. Second is the glomerular basement membrane, GBM, a specialized extracellular matrix layer. The GBM acts as a major physical barrier, particularly to larger proteins, and also has negative electrical charges that help repel negatively charged proteins like albumin. Third, and perhaps most critical for protein retention, are the podocytes.
The cells with feet.
Exactly. These are highly specialized epithelial cells that wrap around the outside of the glomerular capillaries. They have interlocking foot processes, and the narrow gaps between these foot processes are bridged by a complex structure called the slit diaphragm. This slit diaphragm acts as the finest sieve, restricting the passage of albumin and other medium to large proteins while allowing water and small solutes to pass through into the tubular fluid. So these layers work together, utilizing both size selectivity and charge selectivity, since both the filter components and most plasma proteins are negatively charged. They repel each other to keep protein in the blood.
So damage to any part of this intricate barrier can lead to glomerular proteinuria.
Yes. And different diseases tend to damage different parts, leading to different patterns of proteinuria. For example, in minimal change disease, the classic pathological finding is widespread effacement or fusion of the podocyte foot processes, and possibly alterations in the charge selectivity of the barrier. This primarily disrupts the size charge barrier in a way that leads to a very selective loss of protein, meaning it's almost entirely albumin that gets through, as albumin is smaller and more negatively charged than other large plasma proteins like immunoglobulins. In contrast, other types of glomerulonephritis might involve more severe damage to the GBM itself or the slit diaphragms, perhaps caused by deposition of immune complexes, inflammation, or genetic defects. This often results in a more non-selective loss of protein, where larger plasma proteins like IgG immunoglobulins leak through into the urine along with albumin because the physical barrier is more significantly disrupted. The text also notes that extensive podocyte foot process fusion, even if primarily affecting selectivity, might also increase hydrostatic pressure within the glomerulus, potentially forcing proteins through larger pores and contributing to more severe non-selective proteinuria in some cases.
This massive loss of protein, particularly albumin, into the urine is central to understanding the clinical entity known as the nephrotic syndrome.
Yes. The text defines the full nephrotic syndrome by a specific constellation of findings. First, massive proteinuria, traditionally defined as greater than 3.5 grams of total protein excretion per 24 hours, or a spot urine PCR ratio 3.0-3.5, plus hypoalbuminemia, low albumin concentration in the blood, typically 3.0 ddl, plus hyperlipidemia, high levels of cholesterol and triglycerides in the blood, and plus peripheral edema, swelling.
But it's possible to have proteinuria above that 3.5 gram threshold without having the full syndrome, right?
Yes, the text clarifies this. It notes that patients, particularly those with conditions like diabetic nephropathy, can certainly have proteinuria in the nephrotic range, i.e. 3.5 GDA, without necessarily exhibiting all the other features like severe hypoalbuminemia or marked hyperlipidemia, at least not initially. But understanding the pathophysiology, the why behind each of the components of the full nephrotic syndrome, is really key to achieving that deeper mastery-level understanding.
So let's break it down. Why do patients with full nephrotic syndrome get such low albumin levels, hypoalbuminemia, and the resulting edema?
The hypoalbuminemia is primarily due to the massive urinary loss of albumin through the damaged glomerular filter. But importantly, the text also notes that there's often evidence of increased catabolism or breakdown of the albumin that does get filtered and reabsorbed by the proximal tubular cells. So the body is losing large amounts in the urine and potentially breaking down more of what it tries to salvage.
And the edema, the widespread swelling, how does that happen?
Edema in nephrotic syndrome is thought to be driven by two major interconnected mechanisms. First, there's significant primary renal sodium retention. The damaged kidney inappropriately holds onto salt, and water follows the salt, leading to an expansion of the extracellular fluid volume. Second, the severe hypoalbuminemia causes a significant reduction in the plasma oncotic pressure.
What's oncotic pressure again?
It's the pressure exerted by proteins, mainly albumin, within the blood vessels that tends to pull fluid from the interstitial space back into the capillaries. When plasma albumin levels plummet in nephrotic syndrome, this inward pulling force is greatly reduced. As a result, fluid tends to leak out of the capillaries into the surrounding tissues, causing the interstitial edema or swelling.
And the body then misinterprets this fluid shift out of the blood vessels as a sign of low effective circulating volume, even though the total body water might actually be quite high due to the sodium retention.
Exactly. This perceived underfilling of the circulation triggers compensatory responses. It activates the renin-angiotensin-aldosterone system, RAAS, stimulates the sympathetic nervous system, and increases vasopressin AVP release. All of these signals tell the kidneys to retain even more salt and water, trying to refill the circulation, which paradoxically just worsens the edema by providing more fluid to leak out. It becomes a vicious cycle. The text also adds a fascinating molecular detail. Some proteases, protein-digesting enzymes. They get filtered along with the massive amounts of protein, can apparently directly activate ENSE channels in the collecting duct. ENSE channels are responsible for sodium reabsorption there. So this activation provides yet another mechanism promoting inappropriate renal sodium retention and contributing to the edema.
It's interesting that the text notes that severe hypertension is often uncommon in many primary kidney diseases that cause nephrotic syndrome, like minimal change disease, despite all this fluid and sodium retention. That seems a bit counterintuitive.
Yes, it can seem that way. The exact reasons aren't fully understood, but might relate to other vascular or hormonal changes occurring in these specific diseases. The other classic manifestations of nephrotic syndrome are also crucial to understand, as they stem from the protein loss and the body's attempts to compensate.
Like the risk of blood clots.
Right. Hypercoagulability, a significantly increased risk of developing blood clots, like deep vein thrombosis, pulmonary embolism, or even renal vein thrombosis, is a major complication. This is thought to be due to the urinary loss of important natural anticoagulant proteins such as antithrombin III, protein S, and protein C, combined with increased production of proclotting factors like fibrinogen by the liver, and potentially increased platelet aggregation.
And the high cholesterol.
Hypercholesterolemia and hypertriglyceridemia are also very common. This is believed to result from the liver increasing its synthesis of lipoproteins, which carry cholesterol and triglycerides, in a somewhat non-specific attempt to compensate for the overall loss of protein, particularly albumin, from the blood. And finally, patients with nephrotic syndrome have an increased susceptibility to infections, particularly bacterial infections.
Why is that?
This is likely due to the urinary loss of immunoglobulins, antibodies, and other components of the immune system, like complement factors, impairing the body's ability to fight off pathogens.
The text includes figure 52-3, which illustrates that a wide range of diseases and even some drugs can potentially cause nephrotic syndrome. It's not just one disease.
Correct. Primary kidney diseases like minimal change disease, focal segmental glomerulosclerosis, FSGS, and membranous nephropathy are common causes, especially in different age groups. But systemic diseases like diabetes mellitus, the most common cause overall in adults, amyloidosis, and systemic lupus erythematosus are also major culprits. Certain infections and drugs can trigger it too. Understanding the full constellation of findings and their underlying mechanisms is absolutely key to recognizing, evaluating, and managing nephrotic syndrome effectively.
Okay, that's a lot on proteinuria and nephrotic syndrome. Let's move on now to the other things we find in the urine sediment. Hematuria, blood, pyuria, white blood cells, and those casts. What's the definition of hematuria again?
Hematuria is formally defined as finding more than a few red blood cells, typically 2 to 5 RBCs per high power field, HPF, on microscopic examination of centrifuged urine sediment. Now, the dipstick test for blood, it's important to remember, actually detects the heme portion of hemoglobin or myoglobin.
So it can be positive even if there are no intact red blood cells.
Exactly. It can be positive in conditions like rhabdomyolysis, muscle breakdown releasing myoglobin, which contains hemin, or significant intravascular hemolysis, red blood cell breakdown releasing hemoglobin, even if the urine sediment shows few or no RBCs under the microscope.
Okay. Now, if you find isolated hematuria, meaning blood is present, but there's no significant proteinuria, no pyuria, and no casts, the text suggests the source of the bleeding is usually from the urinary tract below the kidney parenchyma itself.
Generally, yes. If it's just lead without other signs of kidney inflammation or damage, the bleeding is more likely originating from somewhere in the renal pelvis, collecting area within the kidney, the ureters, the bladder, the prostate in men, or the urethra.
And visible blood.
Gross hematuria, where the urine is visibly red or brown, especially if it's accompanied by blood clots, is a particularly strong indicator of bleeding from the lower urinary tract, bladder, prostate, urethra, or maybe the renal pelvis or ureters, because clots typically don't form within the tiny confines of the nephron tubules themselves.
What are the common causes of this kind of isolated, likely non-glomerular hematuria listed?
The text lists several common causes: kidney stones, nephrolithiasis, urinary tract neoplasms, cancers of the kidney, ureter, bladder, or prostate, infections like urinary tuberculosis or hemorrhagic cystitis, trauma to the urinary tract, prostatitis, inflammation of the prostate, or benign conditions like BPH. Figure 52-2 provides a nice systematic algorithm for evaluating patients presenting with isolated hematuria.
It's important to distinguish between just finding blood once versus persistent or significant hematuria, right?
Absolutely. A single finding of microscopic hematuria on a routine urinalysis is actually quite common and often turns out to be transient and benign. It can be caused by things like recent vigorous exercise, sexual activity, menstruation in women, or a mild viral illness. However, persistent microscopic hematuria, generally defined as finding more than 3 RBC NSHPF on at least 2 or 3 separate urinalyses spaced weeks or months apart, or a single urinalysis showing a very large number of RBCs like 100 per HPF, or any episode of gross hematuria, always warrants a full diagnostic investigation.
Why the full workup?
Because persistent or significant hematuria is associated with a notable percentage, cited as around 9.1% in one study mentioned, of underlying potentially serious renal or urologic lesions, including malignancies. The suspicion for urinary tract cancer as the cause increases significantly with age, especially in patients presenting with painless gross hematuria and who have risk factors like smoking history.
The text also mentions a couple of treatable metabolic risk factors for unexplained isolated hematuria.
Yes. It mentions hypercalciuria, excessive calcium excretion in the urine, and hyperuricosuriia, excessive uric acid excretion. These conditions can sometimes irritate the urinary tract lining and cause microscopic bleeding. The text notes that dietary interventions aimed at reducing urinary calcium and uric acid excretion can sometimes resolve the hematuria in these cases.
Now, shifting gears slightly, hematuria can also be the only initial sign of significant glomerular disease, even before there's obvious proteinuria or a drop in GFR. How do we tell if the hematuria we're seeing is coming from the glomeruli versus from the lower urinary tract?
This is where carefully examining the shape of the red blood cells in the urine sediment under the microscope becomes crucial. Red blood cells that have originated from bleeding within the glomerulus and have had to squeeze through the damaged filtration barrier and then travel down the long, tortuous kidney tubules are often subjected to mechanical stress in varying osmotic and pH environments.
Which makes them look different.
Yes. They often become dysmorphic, meaning they have distorted, irregular shapes.
Oh.
They might look fragmented, have membrane blebs, or take on a characteristic appearance sometimes described as acanthocytes, which look a bit like Mickey Mouse ears or have spiky projections, when examined carefully, ideally using phase contrast microscopy. Finding a significant percentage of these dysmorphic RBCs in the urine sediment strongly suggests a glomerular source for the bleeding.
So finding lots of these oddly shaped RBCs points towards the glomerulus.
That's a very strong clue, yes. However, the text again adds important caveats. The appearance of RBCs can be somewhat affected by the urine's pH and osmolality, even without glomerular damage, and there is definitely observed variability in reliably identifying and quantifying dysmorphic RBCs. It requires expertise and often specialized microscopy. But when you see clearly dysmorphic RBCs, especially in combination with significant proteinuria, and most importantly those red blood cell casts, the evidence points overwhelmingly towards a glomerular disease process.
And finding those RBC casts, the cylinders literally packed with red blood cells, is the ultimate clincher, the real red flag for glomerular bleeding.
It truly is. As the text states repeatedly, the combination of hematuria, especially with dysmorphic RBCs, plus the presence of RBC casts, plus significant proteinuria, generally 500 mg or certainly 1 g/day, is considered virtually diagnostic of active glomerulonephritis, and it's usually a compelling indication for proceeding with further investigations, often including a renal biopsy, to determine the specific type of GN and guide appropriate treatment.
What are common causes of isolated glomerular hematuria where blood, often microscopic and dysmorphic, might be the main or only finding initially?
The text mentions 3 common ones. IgA nephropathy, the most common primary GN worldwide. Hereditary nephritis, like Alport syndrome, which often comes with a family history and sometimes hearing loss or eye abnormalities. And thin basement membrane disease, also often familial and generally benign. Distinguishing between these often requires careful clinical evaluation, family history, and sometimes renal biopsy, especially for IgA nephropathy.
Okay, that covers hematuria well. What about pyuria, finding white blood cells in the urine?
Pyuria is the presence of white blood cells, WBCs, usually neutrophils, in the urine, typically defined as more than 5 WBCs per high power field in the sediment. If you find pyuria and bacteria are also seen in the urine, either on microscopy or culture, that's the classic picture of a bacterial urinary tract infection, UTI, like cystitis, bladder infection, or pyelonephritis, kidney infection.
And if you see actual white blood cell casts along with the pyuria and bacteria,
finding WBC casts strongly suggests that the infection and inflammation have reached the kidney parenchyma itself. It's indicative of pyelonephritis, as the casts form within the inflamed kidney tubules.
Now, what if you have pyuria, lots of WBCs, but no bacteria are detected on standard urine culture? That's called sterile pyuria. What could cause that?
The text states that sterile polyuria should raise suspicion for conditions other than typical bacterial UTI. Possible causes include urogenital tuberculosis, which requires special cultures to detect, ongoing or resolving acute glomerulonephritis, where inflammation causes WBCs to enter the tubules, or various tubular interstitial processes. These include allergic interstitial nephritis, especially drug-induced, chronic interstitial nephritis from other causes, or kidney transplant rejection, all of which involve inflammation in the interstitium and tubules, leading to WBCs in the urine. So finding WBCs, or even WBC casts, isn't exclusive to infection. They're also seen in these non-infectious inflammatory conditions affecting the glomeruli, or the tubulointerstitium.
Finally, before we leave casts, what about the casts seen specifically in chronic kidney disease?
The text mentions two types often associated with advanced CKD, waxy casts and broad casts. Waxy casts are thought to represent a later degenerated stage of other types of casts, like cellular or granular casts, that have remained in the tubules for a longer time. They often look smooth, refractile, and may have sharp edges or cracks. Broad casts, as the name implies, are significantly wider than other casts. They are believed to form in tubules that have become markedly dilated and hypertrophied as compensatory mechanism in kidneys that have suffered extensive long-standing damage and loss of nephron mass. Finding numerous waxy or broad casts in the urine sediment is generally considered a sign of advanced chronic kidney disease.
Okay, so we've covered protein, red cells, white cells, and the different types of casts and what they signify. Let's wrap up this segment by looking at abnormalities of urine volume, specifically focusing on the opposite of oliguria, polyuria, or excessive urine output.
Right. Polyuria is formally defined as the excretion of an abnormally large volume of urine, typically considered to be greater than 3 liters in a 24-hour period for an adult. The text notes that patients sometimes have difficulty distinguishing true polyuria, producing a large volume, from just increased urinary frequency, urinating often but maybe small amounts each time. So if polyuria is suspected, a timed 24-hour urine collection to accurately measure the total volume is often necessary as a first step, as outlined in Figure 52-4.
Once you've confirmed true polyuria, the text describes 2 major underlying mechanisms that can cause it. What are they?
Yes, it boils down to 2 main possibilities. Either the patient is excreting an abnormally large amount of non-reabsorbable solutes in their urine, which osmotically pulls water along with it. This is called a solute diuresis. Or the patient is excreting inappropriately large volumes of water itself, usually because of a problem with the body's system for regulating water balance involving the hormone vasopressin, AVP, also known as antidiuretic hormone, ADH. This is called a water diuresis.
So too much stuff pulling water out, or just too much water itself being lost. How do you distinguish between these 2 fundamental mechanisms?
The key diagnostic test is to measure the urine osmolality. Osmolality tells you the concentration of dissolved solute particles in the urine. Remember, the average healthy adult needs to excrete roughly 600 to 800 millismoles of solute per day, mainly urea and electrolytes, to get rid of metabolic waste. They can do this in a varying amount of water depending on their hydration status.
So if you measure the urine osmolality in someone with polyuria and it's quite low, say less than 250 mosmol, typically much lower, maybe even below 100.
That strongly indicates a water diuresis. The total amount of solute being excreted per day might be perfectly normal, around that 600-800 mosmol range, but it's being excreted dissolved in a very large volume of inappropriately dilute urine. This happens when there's either a primary problem of excessive water intake, which suppresses the body's AVP release, or a problem with the AVP system itself. Either not enough AVP is being produced or released, or the kidneys aren't responding to it.
What causes this kind of water diuresis?
Causes include primary polydipsia, which is simply drinking excessive amounts of water. This can sometimes be psychogenic, due to a psychiatric condition, sometimes just habitual, or occasionally related to neurological issues affecting thirst or certain medications that cause dry mouth. This high water intake physiologically suppresses AVP release from the pituitary gland, leading to dilute urine. The other major causes fall under the umbrella of diabetes insipidus, DI. This isn't related to blood sugar diabetes, but means the body can't conserve water properly. It can be central DI, where the problem is inadequate production or secretion of AVP by the brain, hypothalamus pituitary, or it can be nephrogenic DI, where the kidneys fail to respond properly to AVP, even if AVP levels are normal or high.
Okay, so that's if the urine osmolality is low, 250. What if you measure the urine osmolality in the polyuric patient and it's relatively high, say greater than 300 mosmol, maybe even significantly higher?
That pattern points towards a solute diuresis. In this case, the kidneys are concentrating the urine reasonably well, but the reason for the large urine volume is that they are being forced to excrete an abnormally large amount of solutes, well above the normal 600, 800 mosmol day. These excess solutes in the filtrate overwhelm the kidney's reabsorptive capacity and act osmotically, dragging water along with them into the urine. So the diagnostic task here becomes identify the excess solute that's driving the diuresis.
What are the most common causes of a solute diuresis?
By far, the most common cause in clinical practice is uncontrolled diabetes mellitus. When blood glucose levels are very high, hyperglycemia, the amount of glucose filtered by the glomeruli exceeds the maximum capacity of the proximal tubules to reabsorb it, the TM for glucose. The excess glucose stays in the tubular fluid, acting as a potent osmotic agent that pulls water with it, leading to glucosuria, glucose in the urine, significant polyuria, and potentially volume depletion and hypertonicity if water intake doesn't keep up.
So always check a blood sugar in someone with polyuria. What else?
Other common, often iatrogenic, medically induced, causes include the administration of osmotic agents like mannitol, used sometimes to reduce brain swelling, or large amounts of intravenous radiocontrast media used for imaging studies. Even providing very high-protein nutritional feeds, like tube feeds, can cause a solute diuresis due to the large amount of urea produced from protein metabolism, which then needs to be excreted by the kidneys.
The text also mentions some less common but important causes related to impaired salt reabsorption.
Yes. Certain intrinsic kidney diseases can cause salt wasting, where the damaged tubules lose their ability to reabsorb sodium effectively. Examples include some forms of polycystic kidney disease, inherited disorders like Bartter syndrome, or importantly, the recovery phase of acute tubular necrosis, ATN, or the period immediately following relief of prolonged urinary tract obstruction, post-obstructive diuresis.
Why then?
In resolving ATN or after obstruction relief, the recovering or previously stretched tubules may temporarily be unable to reabsorb sodium efficiently. Since sodium is the major extracellular solute, this impaired reabsorption leads to significant salt loss in the urine, natriuresis, and because water follows sodium, it results in a significant polyuria, a solute diuresis driven by salt loss. These patients can become quite volume depleted if fluid intake doesn't match the losses.
Okay, let's circle back quickly to diabetes insipidus DI, the cause of water diuresis when AVP is the problem. You mentioned central versus nephrogenic DI. Can you elaborate?
Sure. Central DI means the problem lies in the brain, specifically inadequate production or release of AVP, vasopressin, from the posterior pituitary gland. This can be idiopathic, no clear cause found, or it can be secondary to damage to the hypothalamus or the pituitary stalk from head trauma, brain surgery, tumors like craniopharyngiomas or pituitary adenomas, infections like meningitis or encephalitis, inflammatory conditions like sarcoidosis or Langerhans cell histiocytosis, or vascular events. Without sufficient AVP signaling the kidneys to reabsorb water, the collecting ducts remain impermeable to water and the patient excretes large volumes of very dilute urine, leading to dehydration and intense thirst if they can't drink enough to keep up.
And nephrogenic DI, the problem's in the kidney.
Exactly. In nephrogenic DI, the pituitary is making and releasing AVP perfectly fine. In fact, AVP levels might even be high as the body tries to compensate. But the kidney tubules, specifically the collecting ducts, are unable to respond properly to the AVP signal. This failure to respond can be due to acquired kidney diseases that damage the tubules or interfere with the concentrating mechanism, such as chronic pyelonephritis, analgesic nephropathy from long-term painkiller abuse, multiple myeloma, amyloidosis, Sjogren's syndrome, prolonged urinary obstruction, or even during the recovery phase of ATN.
Are there common drugs that cause nephrogenic DI?
Yes, absolutely. The classic culprit is lithium, which is widely used to treat bipolar disorder. Lithium directly interferes with the AVP signaling pathway in the collecting duct cells. Another drug mentioned is democlocycline, an old tetracycline antibiotic sometimes used off-label for SIDH. Other conditions that can impair the kidney's response to AVP and cause a nephrogenic DI-like picture include chronic electrolyte disorders like hypokalemia, low potassium, or hypercalcemia, high calcium. There are also rare congenital forms of nephrogenic DI caused by genetic mutations in the AVP receptor, V2 receptor, or the aquaporin 2 water channels that AVP acts upon.
So if you have a patient with polyuria and dilute urine, low osmolality, you need to figure out if it's primary polydipsia, drinking too much, central DI, not enough AVP, or nephrogenic DI, kidney not responding to AVP. The text outlines some diagnostic tests for this in figure 52-4.
Right. The goal of these tests is fundamentally to determine two things. One, is the patient's body appropriately releasing AVP in response to a dehydration stimulus? And 2, are the patient's kidneys appropriately responding to AVP by concentrating the urine? Measuring plasma AVP levels directly during dehydration can be very informative, but it's technically difficult and not widely available. Measuring copeptin, a more stable peptide that's co-released with AVP from the pituitary, is becoming a more accessible and reliable alternative biomarker for assessing AVP release.
What about the classic water deprivation test?
The classic approach is the water deprivation test. The patient is carefully monitored while being deprived of water for several hours, causing mild dehydration. You measure their urine volume, urine osmolality, and plasma osmolality periodically. The goal is to see if the dehydration stimulus causes their urine osmolality to rise appropriately, indicating both AVP release and kidney response. This test is often followed by administering a dose of exogenous AVP, usually it's desmopressin, DDAVP, to see if the kidney can concentrate the urine further in response to the hormone.
How do the results differ?
In central DI, the patient won't be able to concentrate their urine much during water deprivation because they aren't releasing enough AVP, but their urine osmolality will significantly increase after they are given DDAVP because their kidneys can respond if the hormone is provided. In nephrogenic DI, they also won't concentrate much during deprivation, and critically, they will show little or no further increase in urine osmolality after receiving DDAVP because their kidneys cannot respond to the hormone. In primary polydipsia, these patients often have a blended ability to concentrate initially due to chronic overhydration, washing out the medullary gradient. But with prolonged deprivation, their urine osmolality should rise somewhat, and they should show a response to DDAVP similar to normal individuals, though sometimes less robustly than someone without polydipsia.
The text also mentions a hypertonic saline-stimulated copeptin test.
Yes, this is sometimes used as an alternative, potentially safer or more efficient way to assess AVP release than prolonged water deprivation, especially in patients where severe dehydration might be risky. It involves infusing hypertonic saline intravenously to raise the plasma osmolality and directly stimulate AVP and thus copeptin release, which is then measured. Different patterns of copeptin response can help distinguish between the different causes of polyuria.
So, understanding these different physiological responses to dehydration and AVP stimulation is really key to pinpointing the underlying cause of the water diuresis.
Absolutely. It allows you to differentiate between behavioral, central neuroendocrine, and renal causes, which obviously require very different management strategies.
Wow. Okay, we have covered a tremendous amount of ground there, going into really significant detail on how kidney function is assessed, the major causes and approaches to acute kidney issues, and all those specific crucial findings you can detect in urine analysis and volume measurements. It's a lot to synthesize.
It is. We really dove deep, and hopefully as we went through it, you could start to see how all these seemingly separate pieces of information, that GFR number, the findings in the urine sediment, cells, casts, the amount and type of protein being lost, the urine volume and its concentration are all interconnected clues.
Right.
The text consistently emphasizes that understanding the specific combination of these findings, the overall pattern, is what allows you to recognize those major renal syndromes we talked about at the beginning, like nephrotic versus nephritic syndrome, or distinguishing prerenal from ATN.
And identifying that syndrome, that pattern, is the absolutely critical first step for narrowing down the potential underlying causes, figuring out which further tests are needed, like serologies or maybe a biopsy, and ultimately guiding the most effective treatment. It's exactly the process the text details for healthcare professionals approaching these complex cases.
Recognizing those patterns is powerful, definitely step one. But what truly elevates understanding, from just knowing the basics to that level of mastery, the kind you see in elite professionals in this field, is really grasping the nuances, the limitations of our tests, and the important caveats we discussed throughout.
You mean things like the inherent limitations of creatinine-based GFR estimates? How they don't rise linearly until significant function is lost, how profoundly muscle mass affects them, the whole complex discussion around the race modifier and its clinical and social implications, and the critical fact that all these estimates assume a steady state, which often isn't true in acute illness.
Exactly. Or knowing the situations where FENA might be misleading in differentiating prerenal from ATN, like in severe heart failure or cirrhosis.
And being able to critically evaluate the urine sediment, recognizing which findings are truly reliable diagnostic clues, like those red blood cell casts being virtually pathognomonic for glomerular disease, versus findings that maybe aren't as useful or specific as classic teaching might have suggested, like the debunked utility of urinary eosinophils for diagnosing interstitial nephritis.
Precisely. Understanding why the standard dipstick misses crucial proteins like Brent's-Jones light chains in myeloma, and grasping the underlying pathophysiology of why conditions like the full nephrotic syndrome cause that specific complex cluster of edema, hypercoagulability, high lipids, and infection risk, not just knowing the list, but understanding the mechanisms.
It's these details, isn't it? Knowing the exceptions to the rules, understanding the why behind the findings, appreciating the limitations of our diagnostic tools, that's what allows you to look beyond just the surface numbers and findings. It lets you interpret laboratory and clinical information with a more critical eye, avoid common diagnostic pitfalls, and really tailor the evaluation and management to the individual patient. That feels like mastery.
That's exactly right. It's moving beyond pattern recognition to deep physiological and clinical understanding. So, how does all this incredibly detailed knowledge, this deep dive into Chapter 52, actually impact you, the listener?
Yeah, what's the takeaway?
By gaining this deeper understanding of how kidney function is measured, what can go wrong acutely, and what all those urine findings really mean, you now have the vocabulary and the framework to look at your own, or perhaps a loved one's, kidney-related lab results with a much more informed perspective.
So when you see an eGFR number or a creatinine level, or hear the doctor mention protein or blood in the urine, you have a better sense of what that finding signifies, the complexity behind its measurement or detection, and maybe what further questions might be important to ask.
Exactly. It empowers you to engage more deeply and meaningfully in discussions about kidney health, to understand the reasoning behind certain diagnostic tests or treatments, and perhaps to better appreciate the intricate and vital signals your body is constantly sending through this critical organ system. This deep dive, drawing directly from the detailed expert-level information presented in this chapter, hopefully provides you with that powerful vocabulary and framework.
It truly is a journey into decoding the vital messages our kidneys provide about our overall health. We've really gone deep into the concepts of azotemia and urinary abnormalities, pulling extensively from this Chapter 52 material. It's undoubtedly a complex area, but as we have seen, it's absolutely vital for understanding health and diagnosing disease.
Absolutely. And the level of detail required, the number of nuances and potential pitfalls we've discussed just in evaluating kidney function and urine findings really highlights the inherent complexity involved in clinical diagnosis, especially in nephrology.
It certainly does. And it leaves us with a fascinating thought to perhaps ponder, based directly on everything we've explored today from the source material. Given these complexities, we've uncovered the inherent limitations of even our best lab tests like creatinine and eGFR formulas, the subtle but critical nuances in interpreting urine sediment findings, the situations where even advanced imaging might not immediately show the full picture. How much will the art of medicine always remain essential in accurately diagnosing kidney issues?
And by the art, you mean that careful, skilled process of taking a detailed patient history, performing a thorough physical examination, really considering the individual patient's context and background, and then skillfully integrating all of that uniquely human clinical information with the objective data from the labs and imaging.
Exactly that. That process of piecing together the full clinical story in a way that no single test or algorithm can fully replicate. How crucial will that human element, that nuanced diagnostic skill developed through experience and critical thinking, always be, running alongside the ever-increasing sophistication of our laboratory tests and imaging technology when we're faced with the challenge of identifying the specific renal syndrome and its underlying cause in a patient?
That is indeed a profound and important question for anyone involved in practicing, teaching, or even just seeking to understand clinical medicine in our modern era. Something to definitely think about.
Indeed. Thank you for joining us for this very deep dive into the many clues our kidneys provide about our health. Keep asking questions, keep exploring, and keep seeking that deeper understanding.